Vardhaman, for inviting me. It's been nice. It's been almost, I think, about 4 years since we've been doing this course, and I think it's great that it's got still got accepted every year, and I congratulate you for that. I've been asked to speak about a couple of topics about laser correction of presbyopia, and I'll be covering a bit on Praveen's topic of monovision, but a lot of it has already been covered, so if there is an overlap, I'll skip through it. I will probably, no financial interest, but it would be nice to have some. I guess I'll start with this random gentleman whose photograph I got off the net. Has some difficulty in reading and printing in dim light, and he's aged by about 45 years. His intermediate vision is also affected and is dependent on glasses, and he wanted to consider whether multifocal contact lens would be an option. Now he's fairly active. He does some diving, he does some biking, but he's finding it difficult to do his regular work, and he's also finding it difficult to do surgery because he's also an eye surgeon. Sorry. So in terms of getting, I'll come back to that patient later, but in terms of laser ablative strategies, there are broadly 3 or 4 multiple options. Monovision, in which the dominant eye is corrected for distance, which we've discussed, and a crossed monovision, which is the dominant eye is for near and the non-dominant is for far, because we know that dominance can switch, and there are multifocal ablations, and also a concept which did come into vogue earlier was intracorneal multifocality, and inlays and hybrid techniques I'm sure Vardhaman will touch upon. Now remember, for a full range of vision, an increased depth of focus of up to 3 diopters would be ideal. That's what most of us usually require, which is for far, distance, intermediate, and computer. And this range usually goes up as you become older. But probably most of us can manage, especially beyond 40, with about 1.5, definitely up to about 50 to 55. And there is definitely some loss of visual acuity in near when you're doing that. There is also well known, and this is now adopted by the IOL manufacturers, where you increase the depth of field by using the concept of aberrations. And if you see the 2 pictures below and above, this is basically a perfectly ideal sharp focus, and with spherical aberrations, both the distance and the near, that is a bit of sharpness, which basically gives you an irregular circle of confusion, and you have a slight drop, not a great amount in terms of contrast. So basically combining the increased depth of field and monovision with good visual acuity is achieved basically for all distances, and this is a concept which is basically pioneered by Zeiss. No financial interest, but they have something called a blend zone, where there is both the dominant and dominant eye have binocular vision, which is probably what a lot of people, especially ametropic and hyperopic presbyopes, tend to use a lot. Now traditional monovision is slightly different, where you do have basically a loss of distance and some loss of near as well, and that is an area where things are not that clear. And in this concept, basically they use a different kind of ablation. The non-dominant eye actually would refract to something like a -1.5, and the surgical presbyopic correction is a concept that has been around now for at least since fellowship, which was almost about 18 years back. And I guess if it's not been confirmed, it is never that perfect. It is, I would suggest, more of an evolving art. In terms of concept, the option is always to increase the depth of focus in both eyes, especially binocular, because we do not use one eye at any one time. We always use both the eyes. For many presbyopes, this can be basically achieved by increasing the high order aberrations, which doesn't give you a lot of refraction, maybe about max about half a diopter. And in the highest levels of acuity and modular transfer function, which is basically an optical bench test, remember that these are not usually prioritized in this kind of a procedure. Multifocal ablations, as I mentioned, was around for almost about 17 to 18 years, where they aimed for a semilunar shaped zone immediately around the pupillary center, whereby you basically staple the central corneal curvature, and they report promising results. Remember, I come from a generation where we did use broad beam lasers. So at that time, there was something called central islands, which was considered a bad effect. Now, with the flying spot, you're actually trying to create the central island. So that's basically what this does. It gives you an additional aspheric ablation or mid-peripheral ablation with the flying spot laser, which steepens the central part, and this is done in the non-dominant eye. So what you end up with is something called a pseudo-accommodative cornea, where you have a peripheral near zone, a central near zone, and this is modified with depending on the amount of correction that you do, and you add this with the presbyopic correction, usually about a diopter plus. Remember that there was one paper which found evidence for delayed presbyopia caused by induced corneal aberrations, especially after PRK. And this they felt was basically because of the induced aberrations. Remember, both Lasik and PRK would induce some kind of spherical aberrations. Lasik is probably another important addition to the techniques of multifocal ablations, and a traditional Lasik which we are all used to create a multifocal surface on the bed, and this reduces the spectacle dependency in presbyopic patients. So you have multiple powers of correction across the cornea. There is also a combination of micro monovision, which we touched upon, where you're aiming for maybe about 1 diopter, and there is then a difference of a focus shift between the eyes, and the distance distant eye is closer to ametropia, and the near eye is definitely more myopic. This does give a higher stereo acuity, and occasionally I do try and do maybe about 0.5 or 0.75 in both the eyes. This also I find tends to give a better balance in some patients who are not able to accept monovision. There are some good published results on presby Lasik and which showed statistically significant differences both for myopic and hyperopic cases when they used a bi-aspheric ablation profile. I will just touch upon something called intracorneal multifocality, where you have concentric rings used to produce a weaker region in the central part of the cornea, resulting in a hyperprolate shape. That means you try and make it something like more conical in the central part. This flapless procedure is restricted within the boundaries of the corneal stroma. There have been something called hybrid techniques, where you use a combination of Lasik and something called supracore and intracore, which causes reduced multifocality in the distance eye, combined with a full multifocality and monovision in the near eye. Maybe about 8 to 9 years back, there was a lot of talk about intracore, where you use femtosecond lasers to make intrastromal cylinders which cause steepening of the central part, though over a period of time they did find that the cornea is elastic and the effect comes off. Camera, I'm sure Vardhaman will touch about, and laser blended vision, where you have moderate multifocality in both the eyes combined with monovision in the near eye. So basically what what Zeiss does is to have a customized procedure, all distances, and almost an immediate effect. Fairly busy slide, but just to touch upon that, what things that are applied to the patient's eye. In micro monovision, you have, I guess this would be my take home slide in terms of what you want to do. In a micro monovision, the dominant eye is planar for distance and the non-dominant eye is myopic for near vision. The depth of field, basically to reduce the anisometropia, you have binocular vision without adaptation time, which basically for a patient's point of view is very important, and the depth of field compensates for the lack of accommodation. So this is the important part. You also need to control the spherical aberration, and a spherical aberration within a certain limit to increase the depth of focus without compromising the perceived image quality. There is also something happening in terms of the patient's cortex, where you have retinal image processing. There is a bit of neural summation, blur adaptation, and over a period of time, usually about a month, there is some neural suppression. When you do micro monovision, the concept is very similar. You do have these things as well, but in the amount of correction you could probably get with micro monovision is less. The only important part in terms of Zeiss, how it differs from the other points, is basically using a larger optical zone and also tends to probably have some kind of a nomogram for functional age. This is how it is entered in terms of the screen, where you have the important of wavefront measurements, you have manifest, and of course the intended correction, what you want to do. So these are important parts about the nomogram that is built into the machine. And what they found, and remember that for almost all LASIK patients, the myopic presbyopes always tend to do better. So you have very good distance and very good near vision. When you look at hyperopic presbyopes, the corrections are still good, but remember that they do tend to lose a bit of reading vision. You can never actually correct them full. And for emetropic presbyopes, which are basically good for distance, you would have good distance vision, a bit of drop of distance, but the reading, they tend to be fairly satisfied. Now, this is basically important to say that there is no loss of contrast sensitivity in these patients, and there is no loss of stereo acuity. So what did we do for this patient? Broadly, the questions for any patient who would undergo LASIK is, would it reduce my quality of vision? Does stereopsis get affected? Will it interfere with surgical work? And what would I do if I do not get an optical result? And what type of procedure, and who would do my surgery? That's important. So in terms of the patient, there is good patient satisfaction. They almost 80% to 90% would actually recommend it to their friends and relatives. It does give good functional vision. The safety and track record of Femto LASIK is fairly well known in terms of safety. The follow-up data and satisfaction of patients who have actually undergone presbyon, and it can be enhanced, and that's an important part. Just like a LASIK, you can enhance this and bring both the eyes to the same level. And there are no permanent visual effects, and any side effects are basically corrected by glasses. And important to remember that this is probably as much correlates to the natural condition of the eye in terms of contrast sensitivity, stereopsis. You can adjust the microscope, of course. If you're an operating person, you can make one eye slightly more myopic. This is the pre-op scans of Dr. Sri Ganesh, where you had pre and post, fairly well-centered, good thickness, and this is the topography. If you compare this with the post-op, you can find that there is basically a bump in the left eye, which is his near dominant eye, and the distant dominant eye fairly well-centered ablation. This is pre-op. This is the post-op atlas. You can make out right fairly good. The left eye, you have a central bump, which basically gives you about a diopter plus of reading vision. In terms of side effects, maybe mild dry eyes, halos at night, which you need to definitely wear glasses, and that's something you could probably not get away from. And the glasses are only required for highway driving. So in terms of the first part of the talk, I'm done. He wanted me to touch also about monovision. A lot of has already been covered. Vardhaman, do you want me to still continue, or yeah? Okay. In terms of monovision, I think the non-dominant eye is corrected for near, while the dominant eye is set for distance. And monovision as a concept can be achieved both by contact lenses, conductive keratoplasty, refractive laser procedure, inlays, and intraocular lenses. Remember that patients with monovision through laser vision correction have better tolerance of monovision than contact wearers. So there is a difference because there is some neural adaptation that takes place. This is basically because of binocular adaptation, less residual anisoconia, and a decreased contact lens discomfort and maintenance. The success rate of monovision lasers is roughly about 70 to 92%, and you need to have good, this is basically related to good intraocular blur suppression and treatment of the anomisometropia. Successful distal correction of the dominant eye, important especially if you need to do a cyclorefraction, and that's something I would recommend definitely for hyperopes. Good stereo acuity, loss of isophoric shift, and the willingness and motivation is important for this patient. The degree of ocular dominance plays an important role in monovision correction, and patients with strong sighting preference tend to have reduced intraocular blur suppression, which can basically give them symptoms, but usually the neuroadaptation would take about 6 to 8 weeks. And these patients also have decreased depth of focus that makes monovision less tolerable. Is there a difference between myopic or hyperopic monovision? Hyperopic patients undergo monovision treatment do better than myopic patients in terms of refractive success and the acceptance of monovision, because remember that a lot of the hyperopic patients see blur for distance and for near. So if you can make one part clearer, they tend to be a lot more happier. There are of course some disadvantages. There is a blur or a fog, glare and halo, especially at night. You can have reduced nighttime vision, depth perception and contrast, and occasionally you can have transient diplopia because of temporary strabismus. Important that you do muscle balance and in all these patients, because occasionally there have been reports of the squint becoming manifest after surgery, especially in hyperopes. Contact lens trials is a good guide. It's probably the most accurate way of simulation of monovision, and this is important that you do if you're planning it. Because of the minimal induced anisoconia and no prismatic effect, this simulation mimics monovision at the corneal plane and can be a good predictor for final patient satisfaction. I'd end with that. Thank you so much for inviting me.